identify early on who's going to go onto what pathway. Right now, it's in a research state. We'll see what happens. But as you go into early Alzheimer's here, you can see the changes. If you had PET scanners, you can notice that there's decreased uptake of glucose in the brain. The hippocampal size will diminish. Performance on neuropsychological testing will diminish in those areas of the brain that have been affected by the process, whether it's a stroke, Alzheimer's, whatever. So the clinical dementia rating might be helpful for you clinically, and you can download this from the website. In addition, neuropsychological testing, if it's available to you, will be very helpful. Now, what are the types of MCI that we're dealing with? Well, there's an amnestic type, which is a precursor to Alzheimer's. It's more common, 2 to 1, than the non-amnestic MCI, cognitive impairment. It can occur in a single domain. So it might just be a little bit of forgetfulness with a little bit of word finding problem. And that's it. Everything else is okay. It may be in executive functioning. Now, I always like to explain executive functioning to people, to those that don't know. If you remember President Nixon's vice president, Spiro Agnew, he was a guy that couldn't walk and chew gum at the same time. And so that's the concept of executive functioning. Do more than one task at once successfully. In any event, you can have object memory impairment. You may have preserved general cognitive function, intact ADLs. The patients aren't demented, but this patient's on the way to Alzheimer's. They may have multiple domains in their amnestic, so some forgetfulness. Now you have subtle defects in executive functioning, aphasia, apraxia, agnosia. Now, I've also included in this handout a quick cognitive screening exam. It looks a lot like the Mini-Mental status exam. And it's fairly straightforward. But at the end of it, there's something that we know that most people who are going to go on to Alzheimer's are going to have defects in visuospatial relationships. So their eye-hand coordination is going to begin to break down early on. Now, if you'll all follow me, I'm going to pretend that you're all in my office at once, and trust me, you're all going to get a bill, believe me. I don't work for free. What I want you to do is follow exactly what I do, okay? Yeah, get close, lady, getting close. Look closely. Yeah, come on. All right. Okay. I can't see every one of you, but yeah, most of you did pretty well. Now, a patient with dementia is not going to do that well. As a matter of fact, they're going to kind of look at their hands and try and figure out what's going on. So you know there's a problem. Now, you have to have good vision. I mean, you can't be blind because it's just not going to work. People have to hear you, you know, because they have to understand what you're asking of them. So those senses have to be relatively intact, and you have to communicate what you want done. Now, there's some other things we can look for. And you can test for this at the bedside, in the office. Something called echopraxis. Now, I want you guys to put your hands out in front of you. If I raise one finger, you raise two. If I raise two fingers, you raise one. Okay, now, a normal patient won't screw up kind of like you guys. No. However, patients with Alzheimer's pretty quickly, They may get the first couple right, but as you keep doing it, they're going to follow you. That's called echopraxis. There's something called anti-saccades. Now, here's what I want you to do. No. You watch me. Watch me. Wait a minute. Don't. Anyway, I'm going to ask you to point to the finger that's moving. Now I want you to point to the finger that's not moving. Good. Now, folks with dementia will keep pointing to the finger that's moving because they've now been set up. They're not capable. So right at the bedside, pretty quickly, with the right complaints, you can figure out who's got trouble. They have to have the senses of vision and hearing intact. Okay. There's another test you can do, and it's a test of praxis. Let's pretend in front of you you have a hammer and a nail. And I want you to pick up that hammer, and I want you to nail that nail into the table. Okay? Let's do it. Great. So you all figured out there was something there you had to hold, there was something there you had to grab, and you had to do this motion. Okay? Folks with Alzheimer's or any other of these dementias will have trouble with that. So there's some simple clinical things you can do right at the bedside, right in the office, to figure out who's got trouble. Now, it only tells you who's got trouble. It doesn't tell you what the trouble is, but it tells you you got some trouble. Okay. Now, in the non-amnestic MCI types, you have an isolated defect in one non-memory domain. So it might just be apraxia, which is what we just did with the hammer and nail. Aphasia, word fluency, difficulty. I mean, you're wearing those things, those round things that kind of help you with the eye thing and you can see. So instead of saying glasses, they're kind of walking around the problem there, okay? Visuospatial, we just did that. And executive function is includes visuospatial, and there are some tests you can do, Trailways A, Trailways B type testing. And as part of, and I don't know how much you guys use this stuff, but in the handout again on the internet, there's the MMSE, the Folstein, which is really actually quite effective in figuring out cognitive impairment in a shotgun kind of way. There's also a copy of the SLUMS, or the St. Louis University Mental Status Exam, which is really geared a little bit more towards people who already have the diagnosis of dementia. And you'll also find on that website the Montreal Cognitive Impairment, or the Cognitive Assessment Scale, which is really geared to frontal temporal type problems, executive functioning. So there are some tools you can have with you in the office at the bedside to begin to identify different portions of the brain in someone who may have some difficulties. So these kinds of testings, and if you want to do it in a more formal way, you get neuropsychological testing, so you can figure out which of these domains you have problems with or your patient has problems with. And they can, again, be in the apraxia, aphasia, visuospatial, executive functioning. If you have frontotemporal problems, executive functioning, then you might look at a patient who's going to have frontotemporal dementia. Somebody who's going to have problems with personality, changes in personality. Someone who's going to have behavioral activities. And something like, I'm sure you've all heard, someone comes to you and says, Mama's not like her. She's someone else. She's never done this before. They say raunchy things or saucy things, and all kinds of behaviors that were never Mama. Well, you think about frontotemporal dementia, frontotemporal process of vascular disease, whatever. You can have it in multiple domains. So you may have a situation that's non-amnestic, but it affects many other domains, and they'll go on to get like Lewy body dementia. Yeah. Sure. Amnestic is forgetful. Non-amnestic is not forgetful. Okay? Risk factors. Well, patients with hypertension, diabetes, men, if you have the ApoE4 allele, or have an increased risk of MCI. Over time, patients with MCI who convert to AD, or Alzheimer's, will shift to a greater preponderance of informant-related symptoms over self-reported ones. So if a patient comes to you and says, you know, I'm forgetting everything, I don't know your name, I even forgot I was supposed to even be here today, who are you? They probably don't have dementia. They probably have other things going on in their life. They are inattentive, ADD, ADHD, drinking, doing anything that has nothing to do with their memory other than you can't learn if you don't pay attention. It's that simple, right? You've all had kids, right? I rest my case. The neuropsychological problems of mood and behavior are more common in people with MCI. So things like depression, things like behaviors that are not necessarily acceptable out in public. You'll see that happen in folks with MCI. Now, we heard about depression yesterday in a beautiful discussion, actually. Depression and MCI are closely interrelated. It's the most prevalent neuropsychological disorder in MCI. However, some of the things that we'll kind of point out from a clinical perspective is that you'll see irritability, anxiety, maybe aggressive type behavior, apathy, delusions. You may not see the picture of a major depressive disorder. So it might not look like the commercial on TV to take venlafaxine or whatever else they're hawking. It may not be that person who's vegetative and down and looking and not moving. That may not be the person you see. As a matter of fact, in geriatrics and the elderly, the major depressive disorder is much less frequently seen than elements of depression. And we'll talk about that at the end because I think it's very, very important. Now, depression and MCI. The relationships between dementia, depression, and MCI is quite complicated. Depression can look like dementia. It even has a name. They call it pseudodementia. How about that? Cognitive impairment is a symptom of depression. So you can have a patient who's really depressed, who has elements of cognitive who have elements of cognitive impairments, who don't have anything wrong with their brain at all, other than they're depressed. Yeah. Depression is probably an early manifestation of cognitive decline, rather than an independent risk factor. So depression, dementia, delirium, they're all on the same scale. They're on that continuum. So patients with delirium look like they have dementia. And you can't really make a diagnosis of dementia in the face of delirium. The trouble is you can't always diagnose delirium because it doesn't always present in an obvious way. In any event, the differential diagnosis of MCI includes psychiatric disease, adverse medication effects. I can't stress that enough. If you've heard of the Beers list, that's great. And I'm not talking about Heineken's and Michelob Light and so forth, although they're very good. I'm talking about Dr. Beers, who developed a list of drugs, medications, that have impact on cognition. And if you're not aware of it, you just look it up on the internet, talk to your pharmacist and your local hospital, institution, wherever it is.